what do you do when you have gone to train yourself? Because here, government training may not be there. I went to several places requesting to be sponsored to train in this area. Nobody, the government was not ready, hospital was not ready. The option I had was to train myself, and I did all of that and came back. So what do you do if you have this kind of experience? I was made to be running general list, general anesthesia list, and do all of that, and I must not be seen doing other things. It was not until at a point when these people came in that I decided that, I really needed to practice what I had learned. So what do you do when you have gone to specialize, you train yourself, and then you come back, you are not given opportunity to practice what do you do?
Okay, thank you very much. I'll use one stone to anesthetize two birds. The first comment, and then the one from Dr. Nehemiah. Yes, we are not too many. One thing good about those of us who trained under the auspices of the West African College of Surgeons or the National Postgraduate Medical College is that we had sound training. We have the core training in anesthesia. That, if you listen to my lecture, I said there is a core training, there's an advanced training, and there's a level of innovation. Now, all of us had the core training, which size a human being. And we are talking about narrowing your focus for purposes of academics and research. That does not strip you of the knowledge you had as from your training under West African College or National Postgraduate Medical College. So you can still function anywhere you are sent to. But when it comes to specialized centers like the teaching hospitals, general hospitals placed in cities where we are most likely to see specialized cases, referred cases, that is where a subspecialist will stay. A subspecialist cannot go and work in rural areas. They are more likely to work in city centers where places that are referral centers. Now going to the second comment or question, a situation where you will finish and then the hospital does not recognize you, they still post you to go and be working in the recovery room or something like that. That should not be. I keep using my own situation as a typical example. If you don't blow your trumpet, everybody is busy. They will not blow your own trumpet. You have to blow your own trumpet and blow it very loud and clear. When I came back, I put facts and figures before the CMD, the City Chief Medical Director, and I told him, look at the mortality rate of the women coming to deliver in this hospital where the source specialist brought a proposal to him. This is what I want to happen, because we have to do this, otherwise this hospital will be riddled up with legal issues. And then he gave me a free hand, thanks to him, Professor Jule. He gave me a free hand, and I reorganized the obstetrics, the anesthesia aspect of the obstetrics anesthesia department. And to the glory of God, I said it in 2018 or 2019 NSA conference at Uyo. Our maternal mortality has virtually vanished. These are verifiable facts. You can go to UPTH and find out, because when I came back, I made it a law that anesthesia for cesarean section is not for all comers. It's for minimum of a senior registrar-led practice. And if a senior registrar is conducting anesthesia for cesarean section, he must be in the theater suit. And by the time we did that and a couple of other things, our maternal mortality crashed. And finally, before I bow out, please, that does not mean that you will not go and do some specialty. When you come back, please, you must make impact. Don't just mention it today, you have been trained in this area. Nobody will listen to it because they don't even understand what you are talking about. I said it, that anesthesia specialty is very large, but even medical profession, our medical colleagues don't even understand us. That's why most times they put us at the same level with nurse and anesthetists. They don't understand us, and they may not understand us if we don't make the impact, if we don't create the enabling environment for them to understand what we are doing. So please, that should not stop us. Like I said, because there's a crocodile in the river, should not stop you from going for fishing. You must go and fish and eat, otherwise you will die of hunger. So please, let's open the door wide for such specialization. And some people are inboxing me saying that the age limit is too small, that they should extend it. It is not our fault. When you are going to other countries, they will put a bar for you. But when we develop our own, which is already in the pipeline process, we can even open it up to 50 years. So because of our own peculiar problems. So for now, age should not be a barrier. Anybody who wants to specialize, you can either sponsor yourself or key into the programs of the West African College of Surgeons. Thank you. And even open it up to 50 years. So because of our own peculiar problems. So for now, age should not be a barrier.
Thank you very much. We are about to end the session. Before we end the session, by the permission of the chair, I have
thank you.
Just to comment on what Dr. Nehemiah asked Professor on them about the. Thank you very much. We are about to end and we don't have the session by the permission of the chair. I have anesthesia. I think Professor Dan has explained everything. Just to, it's not every hospital that you will be lucky. You will tell the CMD, give a proposal, and they will give you a free hand. We trained in Israel, Organ before me, I went after him, and I came back, I gave the proposal for obstetric anesthesia and for pain management. And they gave me a free hand, but till today nothing is happening. Till today the head of O&G is calling me that your people are not doing the epidural, so that we suffer to set up. I said, what will I do? Even in this Abuja, in this conference on Monday, a patient who is a professor's daughter, she's a sickler, and she has had 2 previous deliveries under epidural. She's pregnant for the 3rd time, and she's calling me. All my people are here, but it's like it's a passion thing. If you're not there, sometimes you can't really drive it. Other people lose the focus. So even if you set up the program, you have to be there to follow it up and to monitor it. Some people are not as interested as you are to continue to do it. That's one aspect. The other aspect is that I don't agree that because you subspecialize, you must do only those things you have subspecialized. Even in UK, Europe, Australia, everywhere, I discuss with colleagues here, they still do general duty. They are pain specialists, they are obstetric anesthetists, they are anything, any subspecialty they are. But they still do general duty anesthesia. So it's a balancing kind of thing. So my comment is, don't despair, just keep doing what you're doing. And if it doesn't work, there was something the chairman mumbled under her breath, but I heard it. So I will say it openly. Set up your own practice. Yeah, set up your own practice. That's just it. That was what I had to do. I had to set up a practice, and I said, well, okay, I know what to do. I have what to do. There's a time for pain clinic in ABTH, but when you come there, this person, there's no radiologist, there's nobody to do the CM for you, there's no this, there's no, the wahala is too much. When you set up your own practice, get the things you need to do what you want to do, then you have the fulfillment, and the patients will look for you. You remember I sent somebody to you, so that's what I want to say about that. So thank you very much for allowing me to comment on that. And with that, I will, if the chair will permit me, we'll end this session. I want to say some announcements. We are really stressed for time. We are 1 hour behind schedule. We have asked the hotel to serve our lunch here because we will not have 30 or 40 minutes to go to the restaurant and come. And from what we had last night, many people complained to me personally, and I have my personal complaints. that going for the dinner was really very stressful. It was, you said? Yes, it was so late. I ate it was like my dinner. That was the first meal yesterday. It was so stressful, and all that. I don't know. We're not getting a very good deal from the hotel. We have made the request they should serve our lunch here. We have paid for it. It's within their premises. I don't know what they are going to do, but that is what we will insist upon because we are paying for the service. We will insist upon it. They should bring the lunch here. We will not stand up to go for lunch, and that's the position. Yes, that's our problem. They said this setup is for dinner, that is not for lunch. We should go there for lunch. So we are not going to go there, please. I want your backing on this, but that is our decision. So the other thing is that we need time to do the last bit of the awards. So we're just going to call up everybody. We will not read the citations. Citations are in the book of awards. So if you need to see the citations, get the book. So we'll be doing the launching and the awards pari passu at the same time. We'll just take 15 minutes and finish that one, and then do the last scientific session so that we can start AGM on time. The other thing I was asked to announce to you is that the elections are going on. It's on your phone. You will get the link. Open the WhatsApp group you have been added to. You will see the link. Just vote. Election will close at 4 p.m. That is what the chairman Elecom asked me to announce to you, Professor Sadiq. So please open your phones. There's Wi-Fi. They've given us the code. Vote now. It will close at 4 p.m. I don't know if there's any other thing.
So I want to thank our last two plenary speakers for their brilliant presentations, and please join me in appreciating them. That's Dr. Ogan and Dr. Kiahara. So we'll quickly move on to the next lecture, which is ERAS, and is to be delivered by Mr. Tapia, Dr. Daniel Tapia. He'll be delivering an ERAS lecture. His citation can be found in the booklet. So, thank you and welcome, Dr. Tapia.
Good afternoon. So we all stand up. We've been sitting for a while. Make it stand up. Stretch it out a little bit. It's great to be here in Nigeria. I was in Rwanda a couple months ago, and I didn't know if I was going to be able to come. But the passion, the motivation, the strong desire from the Nigerians in Rwanda is palpable to improve it. It's a delight to be here. All right. You can sit down.
Are we good, Captain?
Over the past 10 years, we've been working really hard to improve airway management with the best, highest quality airway equipment available in the world for every situation where a patient is intubated. One of the microphone kind of goes in and out. A corollary to airway management, ERAS, enhanced recovery after anesthesia, after surgery, which is perhaps the most effective, powerful. Enhanced recovery after surgery, which is one of the most effective, powerful, and interesting innovations in anesthesia for the past 30 years. Enhanced recovery after surgery began in the year 1990, 32 years ago. Is this a little bit better? Enhanced recovery after surgery was founded 30 years ago by a colorectal surgeon, Henrik Kellick, to optimize and improve a number of parameters. Early ambulation, patient education, removal of nasogastric tubes, diminishment of fasting, multimodal analgesia, less narcotics, regional anesthesia, a whole slew of factors, and did extensive, in-depth studies to validate all of these principles. So ERAS is a scientifically proven standard of care practice to optimize patient management and improve outcomes, diminish morbidity and mortality, and provide for early discharge with better surgical outcomes and less pain. I'm going to talk to you today about 2 of those concepts. There are about 30, but we'll focus on 2. One is diminished fasting with the use of carbohydrate-rich drinks pre- and post-operatively to diminish the fasting period. And the second recommendation is the use of multimodal preemptive anti-inflammatory medications before the surgery. So that translates into using a carbohydrate-rich drink that the patient takes in sips before the surgery, up to 2 hours, but my recommendation will be 1 hour before surgery, and I'll tell you why. And that they're allowed to do so again in the recovery room once they're awake and conscious. The second recommendation is that they use oral acetaminophen, paracetamol, or Tylenol before the surgery if they have no signs of gastroparesis, right? So they're not nauseous, it's not a trauma, they haven't received morphine, it's elective surgery, that they receive that medication preoperatively, and they receive it in combination with an NSAID, such as a COX-2 inhibitor, preoperatively if there's no major risk of bleeding after the surgery. So just acetaminophen if it's cholecystectomy, knee arthroscopy. If it's a thyroidectomy or tonsillectomy, don't give the NSAID, just keep it acetaminophen. Those are the 2 recommendations. So to start on fasting, the first question I'd like to ask is, how long do your patients fast before surgery? Right? We can all answer that in your head, or you can answer it out loud. Most people will say, well, we fast 8 hours. 8 hours from a big, large, proteinaceous, fatty meal, 6 hours from a small meal, maybe carbohydrate rich, 4 hours for breast milk, and 2 hours for a clear liquid, right? That's the standard of care that we've all been ingrained in. And that was a result of ERAS, right? Before ERAS, it was NPO after midnight for everyone. But with the advent of ERAS, they changed that recommendation to allow for clear liquids up until 2 hours before surgery. And that's the standard of care that we're accustomed to. Now the question is that true for all patients? Or do some patients have a longer fast? And the answer is clearly yes. The median fasting time for most patients is 36 hours around their surgery. 36 hours. So in fact, they eat dinner the night before at 7 p.m. They come in for their surgery at noon, because not every patient can be the first case. They go to the recovery room at maybe 3 p.m. Do they eat and drink in the recovery room? Not often. They may go to the room and they miss dinner. And so they have breakfast the next day at 7 a.m. So you can imagine those patients have 36 hours of fasting. Now, they've found with these studies that prolonged fasting has severe physiologic effects that harm and inhibit the ability for the patient to heal after surgery. And that takes the form in insulin resistance. And it's a well-documented phenomenon that's been used for 100,000 years to keep patients alive in the face of starvation. Right? For many years, patients starved to death. So with insulin resistance, it's an evolutionary change to keep the patient alive. So rather than the nutrients in the bloodstream going to their muscles, their organs, it's saved primarily for the brain to maintain the patient living during this crisis of starvation. And that turns out to be the opposite of what someone needs. The most essential factor after surgery is that your insulin functions well to promote wound healing after the surgery, so that you're able to have insulin function appropriately and bring everything needed to cause scar formation and to avoid infection. If we have prolonged fasting, that inhibits insulin's ability to do so. And in addition, as a consequence, we have post-operative hyperglycemia, right, from insulin resistance. and that hyperglycemia causes osmotic diuresis, dehydration, and inhibits neutrophils from functioning appropriately, which inhibits their ability to fight the infection of the surgical wound. Lastly, prolonged fasting causes gastroparesis. And that gastroparesis allows the stomach acid that's naturally produced to continue to accumulate in the stomach and predisposes the patient to potential aspiration. Because after 12 hours of fasting, the patient doesn't have an empty stomach, right? We've all had a patient, we mask induce, we intubate, we place an orogastric tube, and we remove 100 mLs of pure green acid from the stomach, maybe 20, 30 mLs, but the stomach always has some degree of acid. By following the ERAS protocols, instead, we eliminate that physiologic response of insulin resistance. We avoid hyperglycemia, we avoid gastroparesis, and we continue to wash the stomach clean and remove that acid so that when the patient comes to the operating room, they have 10 mLs of maybe water, 20 mLs of water in their stomach, rather than that residual acid that results in gastroparesis. So the question is, which would you rather have placed into your lungs? Right here, right now. 10 mLs of pure acid produced by the stomach, or 10 mLs of water, right? It's an easy question. And then we ask ourselves, what do we do when the patient aspirates? About 4 months ago, I shared an anecdote. I was taking care of a patient in the operating room for a knee arthroscopy, had a laryngomastoid airway, 12 hours of fasting. Everything was wonderful. Halfway through the surgery, sitting there, I noticed copious green fluid pouring out the patient's cheek onto her pillow. I immediately get succinylcholine. I intubated. I placed the suction catheter, removed as much as I could. And the next step was I took a syringe, 30 mLs, aspirated from my IV line, and put 30 mLs of normal saline down the patient's trachea, right? Lavage, aspirated a little bit more, got the remaining. Luckily, the patient was fine. There was no clinical aspiration. But how ironic, how incredibly ironic that the first thing we do when a patient aspirates is we pour copious amounts of water into their lungs, right? That's the treatment. So the idea that we would be afraid of the patient taking sips of a clear liquid or water makes no clinical sense. And if we look at the anatomy and physiology of the patient, in fact, drinking that carbohydrate-rich drink that's a clear liquid washes the stomach free of that acid so that it's not present in the stomach when they come to the operating room, and avoids all of those physiologic complications that delay wound healing and surgical recovery after the case. So another interesting point to keep in mind is that the absorption of a clear liquid follows first-order pharmacokinetics. And that means that it diminishes by half every 10 minutes. So this bottle of water is 60 mLs, but let's say it's 100 mLs. If you were to drink this entire bottle of 100 mLs 30 minutes before surgery, is that standard practice in your hospital? No. Let's say they do. 30 minutes before surgery, they have 100 mLs. 20 minutes before surgery, they have 50 mLs. 10 minutes, they have 25. And when they enter the operating room, they have 10 mLs of water, clear liquid. Rather than 20 mLs of pure acid, every patient that fasts has between 10 and 20 mLs of pure acid in their stomach. Every patient, no matter what. If you fast for 5 hours, 8 hours, 12 hours, 24, you have at least 20 mLs of acid in your stomach. Now, by allowing them to drink this entire bottle 30 minutes before surgery, you're left with 10 mLs of water in the stomach rather than that 20 mLs of pure acid. So not only is their gastric volume diminished by doing so, but it consists of water instead of pure acidic fluid. Now, it's the standard of care, established globally at 2 hours. It has been changed to 1 hour by many major anesthetic societies. The Society of Anesthesia for Europe, for France, for England and Ireland have all changed the fasting requirements to 1 hour for clear liquids. Now, other institutions have taken that a step farther. There's a big study which was fundamental and swayed me to this direction of promoting this. They allowed patients to take sips of clear liquids until they enter the operating room. Not an hour, not 2 hours. They ignored all time frames and all quantities. Take any volume of clear liquid you want, any time, until you enter the operating room doors. And they didn't have 100 patients. We've seen studies up here, 10 patients, 100 patients. They didn't have 1,000. They didn't have 5,000. They had 10,015 patients. All of them taking any amount of clear liquids until they enter the OR. Now, the established incidence of aspiration is 10 in 10,000, 0.1%. So it's very rare. It's very rare anyways, right? And they found that by following this protocol, they diminished the incidence of aspiration by 70% to 3 in 10,000. And those 3 patients had issues already. They were vomiting before surgery. They had bowel intestinal dysfunction. So the study clinically, scientifically proves that the number one most important thing to diminish aspiration and keep the patient safe is to allow them to drink clear liquids, sips at a time, until they enter the operating room. That's the science. That's what we have today. So I don't know who this water belongs to, but I will pay you back. Hey, may I have your water? Okay, thank you. So what I like to do is think, if someone takes a drink of water, how do they take a drink? Do they stop? They take a sip. And that's not even very much, but I had as much as I wanted to. So when someone takes a drink of water, they don't drink all at once. They take a sip. This is 60 ml, so I took 10 mLs of water. And that was enough. And you put it to the side. You could do it yourself later on. You know, wait till you're home, take a sip of water, take as much as you want, see how much you have. 60 mLs, I just took 10 mLs. That's the way a normal person drinks. They take a sip, they put it to the side, they let it relax. They come back later and have a little bit more. So talking about quantities and volumes clinically makes no functional sense. Just allow someone to take sips of clear liquids as much as they want, maintain their hydration, avoid insulin resistance, avoid gastroparesis, and avoid all those physiologic changes which cause harm to the patient, ultimately in their postoperative care. So it's overwhelmingly convincing that taking sips of a clear liquid, allowing them to do that until they enter the operating room, diminishes aspiration. However, we don't have to be on the extreme, on the forefront. The only suggestion that we're giving is to follow the recommendations that we knew at the start of this talk. The fasting requirements globally is clearly 2 hours. And for most anesthesia societies, they're going down to 1 hour, and it's been clinically. Gastric volume is the same, either 1 hour or 2 hours. Exactly the same, and there's no difference, because it follows first order pharmacokinetics. 30 minutes really is the same as an hour, but it's been proven an hour is the same as 2 hours. So the recommendations that we'd like to give you today is that institute ERAS in your hospital. Follow the guidelines. It is nothing new. It's 32 years old. There are countless studies proving its efficacy. The preoperative area, have a clear liquid juice full of carbohydrates, and allow patients to take sips until an hour before their surgery. And at that point, allow them to take acetaminophen, or if there's no risk of surgery, allow them to take an NSAID. Now, for the recommendation, preoperative multimodal anti-inflammatory medications. For 100,000 years, when someone had an injury, the most likely cause of death was not from the injury, but from infection and sepsis. That's been common. So the body's natural evolutionary response is with inflammation to fight that infection at the site of injury. That's been the case for 100,000 years. However, with surgery, that inflammatory response is now no longer necessary. Okay, 2 minutes. That inflammatory response is no longer necessary. We have a surgical prep that's clean, sterile gloves, sterile gowns, and we found the inflammatory response to surgery actually causes harm. It causes anatomic changes in the nerves from the release of sodium, potassium, and chloride, which upregulates the glutamate receptors up to 50%, which is neuroexcitatory, causes the nerve to arborize and grow, and all of that leads to more severe acute pain, more severe chronic pain down the road, which can be up to 25% of common surgery, and leads to incidences of hyperalgesia with greater pain than they'd otherwise receive. We can fight pain before it starts by using anti-inflammatory medications to prevent those anatomic changes from taking place. How wonderful, how incredibly powerful these techniques can be, not just in major hospitals, right? How many of you would like to have a Da Vinci robot in your hospital, right? Surgeons in the back corner operating. It happens frequently in the room every once in a while, just operating in the back. They're excellent. Every hospital in the world can have a Da Vinci robot. Maybe every hospital can have a video laryngoscope. Hopefully that'll happen in 4 to 5 months. Let's make it happen. But tomorrow, the day after tomorrow, every hospital in Nigeria can make this simple, effective, and incredibly powerful change to improve patient outcomes, diminish infection, improve recovery, diminish pain with minimal expense by following the clinical evidence that's already been established. It's sized, it's laminated, it can go in the preoperative area, and it's a conversation starter that we can follow the guidelines. That 1 hour before surgery, patients be allowed to take sips of a clear liquid full of carbohydrates, and 1 hour before surgery, patients may take an anti-inflammatory COX-2 and COX-3 inhibitor to diminish the inflammatory effects of pain before they start. We also created little ERAS bags. It has the drink, it has the medication, it's free to everyone. You can take it to your hospital, talk to your surgeons, talk to your anesthesia providers, your nurses, your PACU, tell them all about the established standard of care, and give it a shot. See how much your patients improve. It's wonderful, it's standard of care, and it's scientifically proven through rigorous studies and the evidence to date. Thank you very much.
Thank you so much, Dr. Tapia, for that presentation, Miras. So we have some awards, but before then, we would quickly go on to the industry presentation. Ailmed. Okay, so we'll take Smile Train first. I think you can meet him personally, one-on-one. He'll take the question. Yeah. Because we are behind time. I know we have a lot to do. Smile Train.
Okay, welcome and good afternoon, ladies and gentlemen. This is Mason from Beijing UMed Corporate Limited. Like I said, I'm from Beijing UMed Corporate Limited. We're focused on ICU and OR solution manufacturing. In big picture, UMed put up a 3-year development plan with a 12 years development. It laid 3 milestones to complete its releases. First is gaining the broader brand awareness in emerging market through marketing activities with reliable partners, Africa, especially Nigeria as the farthest growing economy. The second is the empowering females for further growth. In general, our products release the ventilator and OR solutions, anesthesia, and some other products. I will give in-depth introduction later by later. As you can see here, this is the emergency ventilator, Shangri-La 510. It's we equipped it for the 2008 Olympic Games. Next is the Shangri-La 510S. Sorry, Shangri-La 590P is an ICU ventilator. This is a VT 5230. It's also an ICU ventilator. This is a Shangri-La 510S. It's an upgraded version of Shangri-La 510. It's designed for emergency transportation and passes EMC test and EN 1789 test. Since it's an emergency ventilator, the tidal volume of Shangri-La 510 is 0 to 2,000 mile. Pneumatic-driven electronic control. It can be used in emergency room and pre-hospital transport, intra-hospital transport, inter-hospital transport, ambulance, and other unsafe situations. This is VG70. During COVID era, we sold 50,000 units in Nigeria. It passes the CE certificate and is an electronic control and electronic driven. The tidal volume is 20. It could be applied to adult, pediatric, and infant. Entire service life is building by turbine is 30,000 hours. 12 inches detachable TFT screen is very convenient for doctors to check the parameter. This is neonatal ventilator. It could be applied to the premature infant. It's under our brand, Germany brand, here, and especially designed for neonatal and a premature infant, which weight from 100 gram to 40 kg. It's non-invasive ventilator, mainly used in PICU and NICU. As you can see here, this is our OR solutions. We can provide anesthetic machine, seating pendants, anesthetic seating pendants, surgical pendant, and endoscopy pendant. And all of our operating table are CRM compatible. And seating mounted operating light also comes with the mobile light. That's all, thank you.
Good afternoon once again. My name is Dr. Charles Ape, Department of Anesthesia at National Hospital Abuja. I was delighted when AMED asked me to review the flagship anesthetic machine, the 8800A anesthesia workstation. Can the slide come up? So AMED obviously has come a long way from their earliest versions in Nigeria, so 200, the 7200 series. People are complaining about many things about that, but obviously this has made giant strides. I'm not going to bore you about the features of a typical anesthetic machine. I'll just go on to the things that make this machine a bit special to me. I don't know why the slides are not coming up. I think I'll have to go on without the slides. All right. Look. Please, that was a little mistake. So, well, let me just go on while we wait for the slide to load up. The machine, you can always walk up to the stand and have a closer look at it. It has a modern look now. It's much more sturdy. The casters, that the wheels are more modern, and they have a central central brake that makes it much more easier to move around. This version comes with a touchscreen monitor, and there is a side LED lamp to light up the workstation. Also, you can extend your workstation by a folding table, which is just by the side of the workstation. So I think that they'll make some strides as per the design of the machine. It looks sturdy and like something that will last quite a while. One of the striking features of the machine is that the flow meters are digital, which for the price I think that's a big stride actually. The thing about the flow meters is that there's also a small feature which they call the I don't remember that now, but I think there's a small feature there that actually recommends how much you can use, how much is safe enough to use to do a low flow anesthesia on patients. Also, there is okay, well, that's the machine I'm trying so hard to describe. It's better you see it than it's described. I probably was doing a very poor job at that. So that's it. That's the 15-inch touchscreen over there to the right, and on the left that's the LED light that lights the workstation, as I mentioned. The casters, as you can see, are large, and there's a central lock. So I'll just skip these quickly. This is the digital flow meter I was talking about, and the feature I was trying so hard to. This next slide. The feature I was trying so hard to remember is this one, the echo optimizer. It's supposed to help dictate how much is low, how flow you can flow, more or less. So these are all just features that you can also find in other anesthesia machines anyway. Now about the vaporizers, it's still your usual vaporizer, but they have gone on to give options to fill up the vaporizers. There's the pour fill, there's the key fill, and the quick fill. I do not know why AMED will still continue to manufacture the pour fill. Pour fill is a technology that just allows you to pour in your vaporizer straight from the bottle into the vaporizer. However, the tea fill and the quick fill will attract anesthetics more, because these will allow more safety infuse more safety into filling the right agent into the right vaporizer. So I think maybe the feedback to AMED to modify their products. The pour fill probably is not a good choice. When I was going through too, I saw that the anesthesia machine had multiple modes of ventilation. I was like, why? But then it hit me again that just recently we had the pandemic, and when that happened, people were clamoring for ventilators. In fact, some other areas, COVID patients were being ventilated with anesthesia machines. So while this has a lot of ventilatory modes, both the pressure control and volume control modes, they are also available on this machine. I think one of the things I'm very proud of on this machine is the ability to do lung protective ventilation, and they use the driving pressure technology more or less. Of course, in addition to the traditional use of low tidal volumes, limited peak pressures, and the use of peak. The driving pressure, which is simply the difference between the plateau pressure and the peak, is a feature that could be used for lung protective strategies. Typically, experts will quote values between 16 and 18 centimeters of water. There is no consensus really as to what value is really safe, but many experts agree that below these levels you should be delivering safe volumes to the patient. The machine also fitted with the ability to view loops and waveforms, alarm systems to various alarm systems, and then for the breathing system. The particular thing I saw about this machine is the fact that you could change your canister, you could change the soda line canister while still ventilating, while still anesthetizing the patient without any interruptions. The machines we have at my center can't really do that. If you need to change, maybe if you have a prolonged surgery, like a neurosurgery or a cardiac surgery, for instance, and you need to change the soda line canister for any reason, you may have to interrupt ventilation. Okay, you may have to interrupt ventilation of the patient by switching to a manual mode and then changing the canister. However, with this machine, you could actually change the canister while ventilating the patient. They call this the CO2 bypass option. Yes, and there's also a driver gas auto switch, which allows you to switch to the driver gas of the ventilator, switches quickly to medical air when you're running low on oxygen, and vice versa. There is an auxiliary O2 flow meter, but this is not peculiar to the machine. The additional thing I think that they have added here is the auxiliary high pressure outlet, which you could use for high flow jet ventilation. So lastly, the anesthetic gas cavity system is also fitted on this base model. Most of the companies will rather you buy this additionally after by purchasing their machine. But AMED has put this up as a bonus on their machine. I think that's basically it. So when you buy this machine, I think it's good value for the money. You could go on and find out at their booth if this is really worth your money. A particular sector will say, you can go and verify. Thank you very much. So that's what I said. You can go verify it at the booth. Thank you, man.
Thank you, Ailmed and Dr. Ape, for that presentation. We'll quickly move to Smile Train.
Standing on the already existing protocol, I'm Ades Emonia, the Smile Train Program Assistant in Nigeria. To take care of children that are born with this congenital deformity, cleft lip and palate. And for us at Smile Train, we have a true sustainable model. We use the local medical practitioners to actually take care of these children in the countries where we operate. For us, we know that statistically that every 3 minutes, a baby is born with a cleft lip or palate. And in Africa alone, 32,000 children are living with these conditions. They are born annually. And for us in Nigeria, we have over 6,186 children living with this condition. Our vision at Smile Train is actually to achieve a world where everyone, whether you are born with cleft or not, you have access to high quality, comprehensive cleft care and is able to live a full and healthy life. And how we do this is by our solution. We empower local medical professionals. We don't just work with the surgeons, we work with the anesthetists, the nurses, the nutritionists, the speech therapists, just to make sure that these children grow and they thrive wherever they are in Nigeria. Smile Train works through partner hospitals. I don't just come into Nigeria and start going to the communities to bring these children, no. I have to go through hospitals like the National Hospital Abuja, the University of Abuja Teaching Hospital, to make sure that I get access to the people that are qualified, that are trained, for them to give this care to the children. In Nigeria alone, we have 54 active partners that help us to carry out this care for these children wherever they are. Smile Train started actively in 2007 in Nigeria, and since then we've achieved 33,368 plus smiles and counting, because currently now we know that there are some hospitals that are currently doing this cleft surgery for these children. And we have 54 surgical partners across the 6 geopolitical zones. Why we actually use the 6 geopolitical zones is to make sure that we bring this care to the doorstep of every child. We want everybody to have access to it. We don't want people traveling from one region to another just to access cleft care. So we spread out to all the 6 geopolitical zones in the country to make sure that people are there to always attend to them. We have the role of anesthetists. In Smile Train, we actually prioritize quality and safety. Because we've had cases whereby we operated on people, adults that are up to 45 years of age. So we don't want a condition where a child goes into the theater and doesn't come out alive. So we actually prioritize safety. And how we do this to make sure that we ensure that every patient receives the safest, as much as it's possible, the safest, the highest quality standard of anesthesia care, and has the best possible outcomes. We don't want parents, instead of us, we have Smile Train, we smile a lot. We cause smiles. We don't want a situation whereby a mother is anticipating that my child is coming out, and all of a sudden it's just a different story. So we make sure that the anesthetists are trained, because we know that their role is very critical when it comes to surgery care. We also develop and implement initiatives that will constantly improve and expand cleft care, and also to empower our healthcare providers. We cannot overemphasize the role of a policymaker around anything that has to do with care, whether healthcare or not. As part of the local, national, and international health policy, we want Nigeria to begin to prioritize, to know that if we have over 6,000 children that are born alone in Nigeria with this condition, that means that we should make it a priority in our healthcare system. We shouldn't just neglect those children, because we know that there is so much that they actually